All right. So we're going to go ahead and get started. And before we get into introductions for panel 2, we've got about 75 participants who are joining us virtually. I want to encourage you to put your questions in the Q&A, and we will get to asking those at the end of each of our panel sessions. So don't be shy. Feel free to put your questions in the Q&A. And we have staff here that will ask them. Okay. So we've heard that focusing on cost impact of adding new benefits rather than the health outcomes can be a barrier to incorporating equity-enhancing benefits. So now we're going to talk about ways to shift this focus and move from cost to cost effectiveness. The panelists for this panel have experience with valuing and studying the impact on cost and outcomes. So our moderator, who is to the side of me, okay, is Andie Christopherson, a member of the Health Equity Committee. We've also are joined by, at the end of the table, Brandon Batiste, Vice President of Healthcare Innovation for Morgan Health, CJ Wolfe, Vice President of Aon. We've got Andie Hiles, an expert on employer-sponsored health programs, and Rachael Zuckerman, who is a social science analyst at the U.S. Department of Health and Human Service, Office of the Assistant Secretary for Planning and Evaluation. And I'll turn it over to you, Andie.
Excellent, thank you. All right. I get to sit on the high chair today. Okay, so talking about cost versus cost effectiveness. As actuaries, we're really good. We've been trained at estimating benefits in terms of costs. We haven't been as trained at how do you measure cost effectiveness. It's much more challenging to look at what the offsets to benefits are. And so today, we're going to talk about the broader impact of benefit changes, not just with costs, but really the total impact, looking at the value that benefits or benefit changes brings and the outcome of those benefits. So we're going to start, Rachael, thinking about your experience researching the impact of various benefits and programs from a federal government perspective. Talk a little bit about how we can go beyond just cost when considering the value of benefit.
Yeah, thanks very much. So I am so excited to be on this panel, and when I saw the title, looking at cost effectiveness, I thought, it's great that you have someone for the federal government, and we're not really allowed to use that in most of our programs, right? And especially programs like Medicare, where we're prohibited from using cost-effectiveness analysis to determine benefits. So we do a lot of things to look at the quality of benefits to see how well programs do without using just that cost-effectiveness lens, which is really nice. So, if we think about CMS, which Krista talked a little bit about, she did a nice intro for me. In Medicare, there are a lot of value-based purchasing programs across many of the different benefit categories. When states have Medicaid waivers, they have to evaluate the quality and outcomes of the changes they made to the benefit. And then, the big one is the CMMI, Centers for Medicare and Medicaid Innovation models, right? So we have a lot of information on that. And we have found that it's really difficult to show cost savings in CMMI models, right? We've only had 4 models be expanded based on an evaluation of savings and quality of over 30 models that have been tested, which is not to say that those models haven't given us a ton of really important information, but we haven't been able to certify them for expansion based on cost. So care transformation is really about a lot more than reducing costs, right? It's about improving the quality of care. It's about improving beneficiary health. And as we heard in the last panel, all of those things are really important from an employer perspective. And I think we're also going to talk about from an insurance perspective how we think about those things as well. As Krista said, there's been a huge commitment to health equity under this administration. So we have a lot of opportunities to think about that. And we've really taken a whole-of-government approach. There's been some White House-led initiatives on this. We have a cross-agency HHS work group looking at health equity, social determinants of health. And I'll just say there should be more to come in the very near future on that. So thinking about how we address not just healthcare needs, but the whole person, right? The and of health and human services, and how we take a whole of government approach for that without medicalizing social needs, because we know that it's not fair to ask the medical system to pay for anything, and it's not the place with the most expertise. So that's really what we've thought about. So there are all these quality programs. We heard a little bit about looking at who has social needs and whether or not they're being addressed. CMS also is looking at differences and disparities in readmission rates. They've been sending hospitals confidential reports on this for years. The physician payment quality program also has some equity measures, and there's a new hospital commitment to health equity. So there's a lot on that. And then we, in ASPE, the Assistant Secretary for Planning and Evaluation, have done some work on equity measures. We looked at 10 different measures. We had one that we thought was the most useful right now, the Health Equity Summary Score from CMS's Office of Minority Health. But there's a lot more to be done, and especially thinking about the different dimensions of equity, not just race and ethnicity, but all of the things that were mentioned earlier today.
Excellent, thank you. Yes. Awesome. Okay, so CJ, based on your experience valuing benefits and programs for Medicaid, can you provide your insights on how cost effectiveness is considered and what information is key to understanding cost effectiveness?
Yeah, hearing Rachael talk about that brings me back to my, 13 and a half years being one of those Medicaid actuaries who would sign or deny one of those evaluations. But, Medicaid, very differently, cost efficacy really just meant the efficient use of public funds, the efficient use of the healthcare dollar. And so, as best we could, we used that as timely as we could find data on the cost and utilization of the services. We did do deep dives into diagnostic information, those procedure codes, everything we could to understand whether or not these Medicaid programs by state or these innovations could actually have an impact on how efficiently we're delivering care. But we were fortunate to have so much longitudinal information about the things that did work in some states, the waivers that had been successful with those states meeting those public health needs. And what we saw really was that large trend of everyone moving out of the fee-for-service into the managed care space. I think it's probably all managed care at this point. I've been out of that game for 5 years. So a lot of those projects and proposals that were coming out of CMS's Innovation Center really took that a step further than just like the managed care approach, and looking at those incentives and the gain sharing based on health outcomes, like the Medicaid ACOs, which I thought were pretty successful in some states, those accountable care organizations, and these were the ways that we were measuring cost efficacy. But kind of doing that with the Medicaid data was looking at it like a ship in a bottle, right? Like you had this 30,000-foot view, and at the end of the day, the programs were really subject to a budget themselves, right? And we were kind of just looking at ultimately whether or not these programs were having an impact on the per capita cost of the programs of the people that they were serving. So it's kind of disappointing that we couldn't go further and really address some of the underlying causes, the equity imbalance and real efficiency. But what's exciting is moving into bringing those ideas into a private space. So full disclosure, I'm now consulting actuary, very different but exactly the same. And it's exciting that we have more of that real-time data, real information from the carriers, from providers, and these data warehouses that allow us to really do those deep dives in real time about the member health and the risks that they face. And then we're applying those advanced analytics and machine learning and all your big buzzwords to really find those opportunities to improve access and outcomes. So I don't know what's been going on in the Medicaid space at CMS with my old friends the last 5 years, but I'm hoping that technology and information kind of finds its way back to that space too.
Excellent. Okay, so we've learned that cost effectiveness is not allowed in Medicare, and it's a bar to hurdle in Medicaid. We're going to ask, Andrew, so we don't get confused, with lots of experience in the commercial space, share your perspective on the importance of considering more than just cost when it comes to equity enhancing benefits.
Yeah, happy to do that. Delighted to be here today. I've given a lot of presentations over the course of my career. This is the first time I've been called expert, so I must have done something right along the way. But I think I've been labeled that because most recently I ran plan sponsor reporting and health equity analytics for a large national health plan. Prior to that, I also ran underwriting and actuarial. Before that, I did management consulting, so if I say anything about the C-suite, that'll come from that experience. And then most of my career, I'm much older than I look, but most of my career was in benefit consulting. So anyway, that's how I got the label of expert. So two key takeaways, I think, on this question. But first, let me just restate the obvious, that the cost is incredibly important to commercial plan sponsors. It's a measure that is used across the organization. And as a result of that, as you radiate out from the benefits and HR team, you get more and more focus on cost and less on some of these other interesting measures that we may be thinking about as benefits and HR experts. So that leads me to key takeaway number one, which is that the benefit and HR team, we really need to step up. We need to be educators and advocates for health equity, because it is not really coming organically elsewhere in the organization. If you're a benefits professional, I think it's really up to you to educate the rest of the HR team and finance and other key parts of the organization. I think some of our employer colleagues would probably echo that. The other key takeaway I will share from my experience is that the best way to introduce new metrics, my view, is not to ignore cost, but to the extent you can link with cost, I think you have a much better opportunity to convince the broader organization of the value of these new metrics. So for example, how would I do that? I might start looking at disparities that we know have a positive ROI. I might look at non-urgent ER, readmission rates. Readmission is average something like $15,000, could be as high as $30,000 for an organ transplant. So I would focus on those disparities that we can really show a tie to a return to the organization from a cost standpoint. And at the same time, I would work on investments in longer-term disparities, like incidence of diabetes, for example, which is a longer-term fix. It's hard to get an employer to think about that when there's so much short-termism as they think about their workforce.
Thank you. All right, so Brandon, how do you consider social determinants of health and health outcomes when you're looking at valuing various solutions?
Great question. I think first you have to acknowledge that it's hard, right? That it's difficult, it's hard, it is resource intensive, very expensive, and particularly, in my position, so in Morgan Health, we focus on trying to improve the quality, equity, and affordability of employer-sponsored insurance. And we do that in partnership with our benefits colleagues with JP Morgan Chase, who really serve as the financial fiduciary, right? And so in doing so and thinking about how do you value social determinant opportunities for solutions, it is challenging. In many cases, it requires a bit of an investment, up front to really help to move the health equity-based needle with some of the measures that my colleagues here have talked about earlier. But as Dr. Singleton mentioned in the previous chat, we know what these challenges are, right? We've been knowing about them since 1985 with the Heckler Report. We know what these measures are, but we haven't really moved the needle. And I think there should be more investment related into health equity-based solutions, point solutions, particularly as part of a benefits package. There are things that I think we can do, and we talked a little bit about some of these earlier. First of which is data integration. We know that there's limited data across the board, but it really should be integrated, regardless of how limited it is. The second is related to risk adjustment. We talked about the opportunity for looking at race and ethnicity, gender, pay tier, all of those things that are really important for developing, really valuing potential solutions from an S2H perspective. And the other part, which my colleague just mentioned a minute ago, is related to the long-term view, right? We don't really have a lot of studies that really look at the long-term impact related to social determinants, right? And partially within my job, many of these companies are trying to keep themselves in the black, right? And so it's hard to make health equity-based investments when you're trying to survive day to day, right? And as I mentioned, those things can be very expensive. I would challenge this group to really think outside of the box, right? Because as we've talked about, starting with some of the introductory comments, all of this work is biased, right? All of our models are biased, our algorithms are biased. But if we think about like concepts like salutogenesis, right, which talks about coherence, right, which really talks about quality of life, there are scales, right, there are rubrics, there are also models that we can take, which really haven't got a lot of uptick here in the United States, but in other countries it has, right? And there's proven studies to show that in partnering, the salutogenic model with social determinants, you can really see, significant impact down the road. Part of that is also thinking about personal determinants of health, right, which I think was created by the AARP and United Healthcare. And in partnering those frameworks with the work that's happening related to social determinants, I think we can see a little bit more expansive outside of just blowing up the model completely. So those are some of the areas where I think we could spend a little bit more time in thinking about how we value social determinants.
Excellent, thank you. So in thinking a little bit about how decisions are made and what we know. So CJ, asking you to put on your hat from today as the consulting with employers and plan sponsors. How do employers commonly approach decision making about adding or modifying benefits?
Awesome question, and you're right. I live and breathe it now, and so I think actually probably everyone in this room has or knows someone that's just sitting on that mountain of data, right? Your warehouse and all the information in the world, but it's pretty worthless unless you actually know what you're looking at, what you're looking for. So employers are asking, they face that understandably tough challenge, covering those rising healthcare costs, staying in the black, Brandon, absolutely, and they still need to offer competitive benefit, but they need to maintain that budget. So I get a lot of those very typical, understandable questions. Where are we spending the most money? Who's costing me the most? The high-cost claimants, what are the top drugs, top conditions? How much is GLP going to cost me, right? And nothing against Tammy and Nathan, you probably live and breathe it too, that these are the things that you're dealing with, and they're fine questions. In fact, sometimes very easy to answer when you have access to the data or the carrier can provide it. But I feel like as actuaries, we have a responsibility to help our stakeholders, any stakeholder, but in this case employers, kind of see beyond that, understand the gaps in not just the healthcare that they're offering based on where the employees are and what they're facing in their healthcare risk, but also the constraints that they experience under the benefit plan itself that they're under. So I know we'll get to a little bit more of that later, but we've seen a lot of success in encouraging employees to invest in their employers to invest in that employee-specific health risk through more advanced modeling of the potential savings that the plan could achieve if they just did some simple things on the front end. It's like I don't know, if we could just increase our cancer screening rates, right, and prevent disease progression for even like a quarter of the people that would get there, we could save them millions. It's very appealing, but at the end of the day, it's impossible sometimes for HR and finance to agree because, you've got to find the money and the buy-in to make those kinds of investments when, like we said, you're not going to save all that money in the first year. So I think short-termism is, I wrote it down, that's a great phrase, but that issue of short-term, short-sighted, short-horizon evaluation of the impact of these benefits is another huge obstacle to achieving cost efficiency.
Awesome. Who else wants to weigh in on what they see on decision making?
I'll just add that, and I kind of said this earlier, health equity is a very new topic to most commercial plan sponsors. I know we had 3 very progressive employers up here earlier, and they talked about the fantastic work that they're doing, and that's to be applauded. But I think most of the commercial market is behind what we heard a little bit earlier. So there's much work to be done. And again, I think that work falls to us as experts in the space to educate our colleagues. In terms of the data that's needed in order to make those kinds of decisions, there's really 2 types of health equity data that I see. One is hard data, and hard data is, I think, CJ, what you were talking about, which is cost, utilization, engagement, and clinical outcomes split by the factors that you're interested in, whether that's social risk or race and ethnicity or other categories. The second type of data, it's almost more information than data, but it's that qualitative information that the 3 employers alluded to earlier, is you need that contextual information that will be able to help point you towards a solution. The data is only, the hard data is only going to tell you this is the magnitude of the problem and this is the sort of dollar opportunity and productivity increase associated with solving that. But getting to the solution is going to require the qualitative data, whether that's meeting, focus groups or surveys or ERGs. So in terms of, does the market have this data? Broadly, I would say yes for leading employers. I would say no for most, and currently no. And I think that problem is particularly acute in the C-suite. Remember, all of us in this space, we've spent years educating finance and others in the C-suite that consumerism is the path to a better health plan. And I think we all know that consumerism doesn't work for low-wage workers, right? If you can't afford to shop, shopping is just punitive, right? So I think there's a role for consumerism out there, but not so much for low-wage workers. So again, I'm sort of going back to my earlier comment that all of us bear the responsibility and the opportunity to educate our business partners in what's going on here and how we can make a difference as an employer.
Can I just add, I think it's also excellent points. I would also say that it's also in the models themselves, right? And in the way that we contract with various groups for point solutions, total cost of care, you name it. It's in the PGs, the performance guarantees. It's in the leading indicators. It's in the contract themselves. And if you asked a lot of these startups, if you had to do it over again, what are some of the things you would look at? A lot of them will say contracting, right? Because once you're in the contract, you're sort of stuck to that. And that could be a year or 2, 3 years down the road. And so I think there needs to be more emphasis put into how do we prepare people, organizations in the benefit design around the contracting, the modeling, because it's antiquated, particularly in a post-COVID environment, right? We have to be a little bit more forward-thinking in some of the ways that we can actually design many of these models that really serve to benefit the employee.
Awesome.
Yeah, I want to extend because I feel like spot on, both of you. I feel like we have that responsibility to not only advance those models and really, we can't just claim savings when we have a good year, right? But holding our partners.
Why not?
Come on. But holding people accountable for the promises that they make, the ROI, and when you're evaluating your own experience and you're kind of telling people this is how much we saved, I feel we have a greater responsibility to make sure like independent third-party analysis is holding people accountable for the solutions that they present and that you're getting what you promise. Nathan is nodding at me really hard right now. That you're promising the Amtraks of the world, and that there's some way to prove that you've bared out that you had the impact. This is especially important when you have 40 point solutions competing for the same healthcare savings dollar, that those methodologies and measurements absolutely have to be advanced in order to make sure that we're not just all claiming we saved the same money.
Yeah. Awesome. So if we think about measuring health outcomes and having that be part of the decision-making process, I guess, Brandon, how easy is that? Like, what challenges have you faced in terms of measuring health outcomes?
Well, measurement is hard, and it's all hard. But when it's easier when you think about utilization metrics, as we all know. Reducing avoidable admissions; those things are easier to track. However, it gets more challenging when you think about quality-based measures as part of an incentive package or looking at total cost of care, and that gets even more challenging when you are thinking about health equity-based measures, social determinants, et cetera, et cetera. I think actuarial work can often be very biased and, just from a black and white perspective, right? Things are very black and white. But I think the opportunity is really spending more time in the gray, which is really where health equity and social determinants, for the most part, lives. And it takes a lot of, work to think about opportunities for measurement. So something that just comes to mind is like BMI, for example, right? Why are we still using BMI, right, as a predictor for obesity? If you look at the history of the vast majority of these measures, they are not meant for everyone, right? The BMI was created, based off an astronomer that had a rubric in the 1800s. And in the 1970s, he did this analysis on 7,400 European men that were 6 feet tall and above. It does not apply for black and brown people, right? And so the reality is that we have to sort of to roll these measures out to the wind, or at least think innovatively about how to bring some of those solutions in. So what we're seeing is a bit of a trend, thinking about waist circumference screening as opposed to BMI. Can we do more of that, right? And thinking about innovative ways to incorporate those things into measurement. That's important because when you're thinking about contractual relationships, integrating those things. There is a ton of work that happens behind the scenes from the clinical perspective and others to really make sure that these measures are met, right? And in meeting them, there are various initiatives, health screenings, et cetera, things that happen to make sure that we could actually close the loop on BMI or diabetes, as my colleague mentioned before. And so I think part of the opportunity of measurement, Andie, is thinking about the actual patient journey, right? Creating these models, thinking about measurement, and if we were to operationalize these, how would that affect the actual patient? How would that affect the point of care related to the employee? And I think if you do that exercise, more often than not, you'll find that there are more disparities than we think, particularly in a post-COVID arena. So the other thing that I will say is that I think a big opportunity is looking at composite measures. We talked about, the Social Vulnerability Index, SVI, and there's tons of different data points that come into that when we think about social risk. And so there should be more focus on looking at composite measures, and also the recognition that there's a lot of things that we do very well related to employer-sponsored insurance and healthcare. And so not every point solution needs to be supplanted. Maybe it needs to be supplemented, right, in a way that it could possibly be integrated in a different way with other measures to support other goals. So just looking at some of the correlations from a measurement perspective, I think, has been a challenge, but also an opportunity in the space.
Awesome, thank
Andie,
you.
Can I just add to that? I would say that, as an industry, so I'm talking about commercial insurance, we really need to up our game in developing proof points around closing some of these health equity gaps. It's just not really there. I mean, if you Google over lunch, proof points that addressing social determinants will reduce costs or improve outcomes, you'll get some literature, but it'll all be Medicaid or Medicare. So there's a lot we need to do on the proof point side, I think, before we're going to get a large swath of the commercial insurance market to start looking at this as a top priority.
No, that's fair. So, Rachael, you have some experience with non-traditional benefits and thinking about how they address health-related social needs. What do we know, and what areas, as Andrew suggested, do we need more information?
So I think, as the last panel said, we know more than we like to admit that we know, right? We've got some good information. We know that only about 20% of health is related to the medical services you use, which means, about 50% is this social determinants of health and health-related social needs, and 30% is sort of other things, health behaviors, genetics, et cetera. But when we're looking at claims to try and understand people's health, you're just missing most of their health, right? You're only getting that little 20%. And so, we've talked a little bit about collecting individual data, using area-level data. Both is really important, right? The place an individual lives says a lot about their access to care, their social determinants, all that stuff. It says some about their individual needs, but you really have to ask them to know what their social needs are, right? So those are two really important pieces, and we're doing a better job of starting to do health-related social needs screening, but it's not perfect yet. So that's sort of where we are in terms of data collection. And we also, as folks have been saying, we have evidence that addressing short-term needs improves short-term health outcomes, especially for specific populations, which is where it's being tested. So, you give somebody who's just been released from the hospital a place to stay instead of being homeless, that's going to reduce their probability of readmission. You give people food, that does help in terms of their healthcare utilization, their diabetes control. But what we don't know is longitudinally, as we've heard, and we don't know for a broader population. And so I think both of those are really important. Longitudinally, eventually they're going to end up in Medicare, so it's great for Medicare if you do something that's going to affect them in the long term. I think that's really much more difficult for the churn in and out of individual health plans, in and out of jobs, right? Thinking about how we, thinking creatively and outside the box of how we understand the benefits of things that really are more short term. I think the other thing that is really challenging, we're doing more about asking people their own experiences. We still don't quite understand when something works, how it works. And I'll pull up the example from the Accountable Health Communities model at CMMI, which is a lot of evaluation reports are coming out right now. So there was screening and navigation to address social needs and to see how that worked. Individuals who received those services, those navigation services, often did not have their needs met, but still reduced their healthcare utilization, right? So how did that happen? Why did that happen? You know, they're doing some qualitative research to understand that. Obviously, it's a good thing. It would be even better if their social needs were also addressed. But really understanding how these interventions are working is very important, and I don't think we have that information yet. So maybe I'll stop there.
No, that's really helpful. Okay, so pivoting a little bit closer to home on what actuaries should think about when pricing new or modified benefits. So, Andrew, what do we need to be thinking about when we're pricing a new or modified benefit design that maybe involves changes in cost sharing and payment, which is, I think, our favorite go-to, adding benefits or new eligible populations?
Yeah, I mean, it's a great question. You know, typically today we look at things like, you know, expected illness burden, or we look at demographics, we look at location, we look at geography. All those things are important. But I think in the future we'll also need to look at the social situation that individuals find themselves in. So if we're building a plan or plan design change for a particular group, what's the lived environment for these individuals? And based on that, these new benefits that we've talked about, whether that's, you know, transportation services or whatever it is, will that have an impact on the pricing? I think today we probably don't do that, but I think in the future, as we get more sophisticated about understanding how social risk impacts health and cost, that those will become part and parcel in our modeling.
So perhaps some of the like heat maps and other things that a company might look at to determine what benefits they would want to, we need an actuarial method for heat maps.
Yes, but I would also recommend greater granularity in those heat maps. You know, we talked a lot today about zip codes. I mean, those zip codes are good, right? That information's available. There's about 42,000 zip codes in the United States, but some of this data can be found all the way at the census block group level. There are 220,000 census block groups. In the U.S., it looks much more like a neighborhood. So as we continue to progress in this area, I think we should think about how do we get more granular with the data. I think it'll make our predictions more accurate.
Great.
So I have to mention, because my Aon colleagues are smiling at me because of the tools that we're making that are doing exactly this and looking at an employer's specific population, where they actually live, where they get care, and trying to assess like what risks those specific populations face. And yeah, it's absolutely critical to identify for an employer how their population, not just how the heat map, but like what's the individual employer's heat map look like for their employees, where they receive care, what are the risks that those people face, and compared to the clinical and actual claims information that they're pulling in. So the heat maps, I think, are a great overlay to identify where those risks live and breathe, but looking at your specific membership and figuring out, you know, who is at risk and at risk for what, and targeting those populations and making sure the benefit is actually reaching the people who need it is absolutely critical.
Can I add a thought to what
Yeah.
CJ just said? I agree with all of that, and I applaud your firm for what you're doing. I think in the commercial space, we need to think a lot about the power of the employer-employee relationship. You know, when we talk about Medicaid and Medicare, that doesn't exist, right? So in Medicaid and Medicare, as they remediate disparities, they tend to really lean into community programs. And that's great, right? Community programs are important, there's a role. But as an employer, right, we touch the employees in a lot of ways. So I think there's lots of opportunities to get employers to think a little bit more broadly about their role in worker health. Ultimately, we may think community programs are part of the solution, but please don't run past that employer-employee relationship.
Yeah. No, that's one thing, you know, thinking about, I think in Annette's introduction, like 42 billion annually is lost from health inequities via productivity. And having done the pricing from a health plan side, that isn't going to get me any cost savings on the health care, but thinking about it from a like more meta perspective, macro perspective from an employer, say having productivity improvements really is a big leverage point that maybe gets us more immediate short-term-ish returns in addition to longer term health improvements. Have you guys, anyone done any?
We're doing a little bit of that, and it just reminds me of the comments that Andie and CJ are making about just the importance of building trust, right? And at least on the JPMC side, we've been spending a lot of time with some of our portfolio companies and trying to develop a baseline for SDOH. And so, as you mentioned before, screening to validate that some of the social needs based on the social risk indicators are actually present. And then once we identify those, how can we actually work to close those gaps? And then understanding those opportunities, having a baseline, are there opportunities for integrated relationships, partnerships, maybe even some incentivization related to areas where we might want to spend a little bit more time. But I really don't want to underscore the opportunity for, and hopefully Dr. Fitzpatrick will touch on this later, about just the importance of sweat equity, right? And making that investment into the coaches, the community health workers, the engagement to really spend time with the employees, because let's keep it honest, like there's a lot of things I don't want my employer to know, right? Related to SDOH needs. And so we got to be very sensitive about those sensitivities from an employer perspective, and recognizing that to the extent that you're building trust, you could be uncovering additional social needs, right? And so there could be a bit of a skew related to some of the data on the employer side. And so, yeah, I just wanted to make the point that the trust part is critical.
Yeah. No, I thought in the first panel what American Eagle, what Tammy highlighted, what really building trust through action taken on information, I think is really huge to make. Yes, there's an employer-employee relationship, but that goes both directions. So
Yes.
if you have to build on that. So, okay, we're going to pivot here in a second, but I just want to remind people we are going to do Q&A. So if folks have questions, or those virtually online, send those in so we can field some questions. So we've been talking mostly this session about the employer perspective. So pivoting a little bit to talk about affordability from a consumer perspective. I guess, Andrew, do you want to talk about the concept of affordability and what considerations you think are most important when considering affordability from a consumer lens?
Yeah, sure. I'll just start with a little data. The Commonwealth Fund says that 29% of people with employer-sponsored health insurance are underinsured, which is their term. Essentially, it says that these people have insurance, but they can't afford to use it. So for them, their $2,000 deductible might as well be a $2 million deductible, and their health outcomes reflect that. So affordability, huge problem in the commercial market. And I'll just say briefly that we need to get away from testing benefit designs and programs on the average employee, because that person doesn't come to work. There is no average employee. They don't show up. We really need to think about how these new designs and programs impact various strata across the workforce and be much, much better at that. I know some employers have been at that for a while, others not so much. I would just say that should become part and parcel of how we think about new plan designs.
Yeah. No, and I know on the Health Equity Committee, when we were first grappling with, okay, what are we looking at and how do we think about it? As an actuary designing a consumer plan or thinking about benefit designs, it's easy to stick yourself as, the consumer you're designing a benefit for, right? That's just human nature. And so thinking about, no, you can't look at the average. You have to look at, the strata to consider how this works, because healthcare, even copays or coinsurance, really is not affordable to so many families.
I just want to repeat and reinforce what our expert is sharing with us, like this consumer-driven healthcare trend, right? That's kind of for the last decade has shifted a lot of the workforce into what we call being functionally uninsured, right? And it's just been you've seen kind of a transformation. Hopefully, most of you are starting to see kind of transformational shifts in how we address that inequity. Just looking at things like variable copays, or pay-based out-of-pocket cost designs, or a kind of an enhanced version of just salary banding, or just focusing on like wellness or well-being as a means to incentivize people to get their annual health checkup, their health risk assessment, and then you give them a benefit that reduces their premiums for the rest of the year. And the premiums being low is one thing, but if you can't afford that $2,000 deductible, which most people can't, then that health care is out of reach. And I want to call to everyone's attention that the apparent savings of low utilization for those plan design changes, it's a false positive. Members are just avoiding care, and you're getting hit hard in years 2 and 3 when people come back to you with the cancer you didn't catch or the diabetes you didn't treat.
So CJ, I was looking at the Kaiser data last night, and they said about 10% of employers have wage-based premiums, but only about 5% have wage-based cost sharing, in-plan point-of-care cost sharing. So long way to go.
You can even go even further, like virtual first plan designs or quality-based design tiering. We need to be driving people to those areas of higher quality care where the costs are the same or even lower because they're out there.
Yeah, Brandon or Rachel, have you seen some of this?
Sure. Well, so I'm going to talk a little bit just about general cost, right? I mean, so like, assuming you can afford it, right? We know that people are responsive to cost, right? That's why we've been moving towards all these plans. We've known that since the Rand Health Insurance experiment. But it's just not enough. I'll just say that again, right? Right? If we are asking people to find high value care based on cost, then we're going to shift them to things with low copays. We're going to shift them to things with but it's not necessarily going to get us to equity, right? And there are a lot of things other than cost that impact equity, right? There's trust in the healthcare system, health literacy, social determinants of health. Like, we need to incentivize those things as well. So I'll just throw that in. Once we make it affordable, we need to also incentivize people to use the care that's of value to them, that we know is going to improve their health.
Excellent. Brandon, how do you think about social determinants of health when you think about person's ability to pay in an innovative space?
It's a great point. I'm thinking about a conversation that Congresswoman Fox, that's in the reception last night, and one of the things she mentioned about employer-sponsored health, if you heard her speak, she often talks about her sister that is a 4-time cancer survivor, right? And that each time she had cancer, she was cured. And she kind of went through the process, she's still in remission. And then I was reminded about my own father, who is a 2-time cancer survivor, and it was through employer-sponsored insurance that he was able to receive the medical benefit. And there was lots of different things, access to point solutions that came with that benefit. But it was the host of a million different other things that interface with that medical benefit, like transportation, like does he have the copay to actually pay for the medications? Is there someone that can pick you up and drop you off for your appointment? All of those social determinants that I think, are really impact the ability for healing. And so when I think about copay, it's like I just think it's just one of those things on the notch of a ton of different things to consider, which in my opinion really can't be isolated when you're thinking about a person's well-being and care. And so as we talked about a lot today, is just thinking about whole person care, thinking about the full ecosystem and the continuum, and how broad costs, not just copays, but all of the costs that come into actually managing someone that is going through, chemotherapy or whatever that treatment option might be. So that's something that initially comes to mind. It's just, looking at the full picture.
Yeah, no, thank you. Awesome. Okay, so we're going to take some questions. So do we have, all right, we have one. Perfect.
Yeah, Ulrich Newman with the Johnson & Johnson. I wondered about, you talked a little bit about moral hazard and that there's literature, but then there's also this phenomenon of behavioral hazard, right? So there's behavioral factors, you have a copay, and people cut the wrong medicines, right? They don't cut the medicines where the copay is on, they cut the most valuable of the medicines, right? And so even if you not have cost shares, you remove, no copays and whatever, you have, these behavioral confounders, right? And so I was wondering, what type of designs, is there innovation in that area to help around, this problem of behavioral hazard?
So I think one of the pieces about behavioral hazard that a thread that runs through a lot of the health equity work is you need to have qualitative information, having, spoke and had a dialogue with maybe the slice of folks where you're seeing that behavior, and really understanding what factors are confounding that. I mean, and so I think that's a first starting point is, okay, you have the data, but really why? Why is that happening? And so needing to not jump to conclusions of what's driving it, so then that's how you're going to fix it, but understanding which populations that's happening with, and understanding all of the kind of environmental factors that might be driving that behavior. I don't know, any other?
If your question is specific to how prescription drug design and formulary limitations, it's important to make sure that we're offering the drugs that everyone needs, but we also want to drive them to efficient use of the drugs that can do that more efficiently, less expensive. And I'm not talking about just blanket cutting out the highest cost drugs, but making sure you have good utilization management, step therapy, all the things that you need for an effective thing. Formulary is the thing. But having a trusting relationship with the providers who are actually prescribing, and this is a big thing with the GLP-1s now, making sure that they have both the freedom and flexibility to prescribe what they know their patient needs without the ability to abuse some of those. I think some people are dispensing prescriptions just to keep the client happy, and I know some doctors are prescribing GLPs that aren't indicated for a condition just to help their patient lose weight. That's their decision. But I'll get off of GLPs. I know it's not the hugest deal right now. But I don't think that it has to be such a strict formulary design that people aren't getting the care they need. There just has to be a more trusting relationship between the employer plan, the sponsor carrier, and provider, and making sure that they can get the actual drug they need. And those, Tammy's probably getting the phone call. If someone's drug is denied because you changed. She's nodding too for people off camera. You're going to hear that call, and then it's our responsibility to make sure that there aren't cracks in the system, or that people aren't having to jump through flaming hoops to get drugs that they got in 2023 just because now it's 2024.
And can I just provide a recommendation? One thing that I would suggest you look at is clinical trials, right? And so one of the things that I think a lot of people don't realize is that when, as part of a clinical trial, there's a whole care team, right? And tremendous oversight that those individuals have as part of the clinical trial, an entire care team. They look at utilization management, the drugs. And so I think there's a lot to learn from an actuarial perspective about how that is managed. And then, pushing access for particularly minorities, Black and brown people, to be a part of clinical trials, because it really is an ecosystem of healthcare professionals that look at every aspect of that person's care. And so I just wanted to make that point that there's a real opportunity there.
And I think also from a regulatory perspective, then publishing the clinical trial results by those slices. I know that including women in clinical trials, that has become more prominent or prevalent, but they don't analyze the data. And so making sure that we get those, it's not just the average, it's you've looked at the slices and make sure that, things are efficacious for everyone.
Exactly.
What other questions?
I may be jumping the gun. My name's Katie Zurich. I'm with Regulatory Insurance Advisors. You talked a lot about trust. The previous panel talked a lot about trust, and employers can build that with their employees. But Medicaid, Medicare, you've already said this, and then individual market insurance companies don't have that trust. And so what can be done and what can be translated to make sure that that trust might exist? Or where do we go next in those spaces? Maybe a question for a different panel.
Well, I will start by saying that there are some things that we are trying to test with some of our payers related to SDOH. And so there is pilot potential, partnership potential with payers related to health equity, SDOH work. There's also a lot that the payers can do that we as the employer cannot do. And so, I think that there's opportunity for cross-pollination in those respects. And there's also, you also get away from some of the things that employer might be prohibited by from a trust perspective, having the payer reach out through a community health advocate versus your employer. All of those things I think helps to push the needle a little bit further. And so there is opportunity that you could explore, with certain point solutions or in thinking about like an innovative product that maybe hasn't gone to market or something that hasn't been turned on, to test with the payer as an example.
Oh, go ahead.
Oh, I can just say, so, I would say that in addition to trust with the employer, there's a lot of trust with the provider, maybe even more than the employer in some cases, right? So in the thinking about federal programs, that's what we really rely on, and we use the one lever we have, which is payment, to incentivize building that trust. So, payment for care management, thinking about paying for community health workers and social work, right? That's a new policy that's being rolled out. Those are ways that we think about building that trust, because, as you say, people's opinion of the Medicare and Medicaid program really varies, shall we say.
Yeah, I think the last component or answer I'd offer to your question is health plans need to put, if you can't just say it, you have to show it. And so really putting the money into and the effort into figuring out what kind of community programs they can partner with. And so kind of figuring out where their populations are and how they can meet them where they are, I think is huge. Particularly right now, health equity is a big deal. So you can, talk about it all day long, but what are you actually doing about it? Because it isn't easy. There aren't pat answers. And if that's what health plans are sharing, then you have to wonder. Awesome.
Yekaterina Bogush. I'm an actuary, and my background is in 18 years in Medicaid managed care space, so my question would be definitely biased in that regard. Do you believe that there is an opportunity in the commercial space to deploy more of the risk adjustment model that is used by the agencies in the states in Medicaid, where the risk adjustment is really a cost-controlling, cost-to-cost effectiveness mechanism? The risk adjustment is budget neutral, where the payer does not pay $1 more, and the risk adjustment is used to shift dollars more to the payers that actually do offer kind of either the network offerings that really serves the rural populations, or again, that difference in disease burden. And that difference could be very substantial. It could be easily 10%. And that really serves as a very kind of big incentive for, and the mandate actually, for the different plan offerings to be more equitable, and it forces those investments on behalf of the kind of the managed care offerings without having the payer to really kind of keep adding and adding and adding and addressing those.
What do people think?
Our expert.
Go for it, and then I'll weigh in as well.
Rachel, I'm looking at you.
Okay. So I can't talk about the private market, but I can talk a little bit about the advantages and disadvantages that we see of using that approach. It does allow for additional benefits to be offered, right? That's a huge pull from Medicare Advantage compared to traditional Medicare, is that there are additional benefits offered. Those are important benefits. They're not necessarily associated with better care, right? And so we don't have the, we can assess care, and if it's really poor, then there are actions we can take, but generally, as long as it is, they're providing decent care, then it just goes forwards. And there are incentives, of course, to code more conditions, right? We can talk about that all day. I think maybe for this group, one of the biggest concerns is that then you don't get the information, right? So we have incredible data on Medicare fee-for-service beneficiaries, which are about half the population right now, and not very good data for Medicare Advantage beneficiaries. So if, from an employer's perspective, if you want to know what's going on with that population, it becomes more challenging when you turn that over to the insurer without a way of obtaining that data. Now, I think employers may have other mechanisms that the federal government doesn't, but that's a challenge we face.
Yeah, I guess my knee-jerk reaction, but in thinking about it, so we know that populations suffering from health disparities are undercoded in claims data because they just aren't getting the care that they need. There's the coding arms race that we have going on in so many spaces. And also, risk adjustment doesn't look at, are you successful with the outcomes? It's more of a process measure. Did they get through the doctor? Did you flag the condition? Not did you actually successfully help the patient towards health? And so I don't think that is really a mechanism that's going to help in this space. I think if we get to a point where we know what kind of levers to pull and what sort of solutions help address health equity, then some sort of kind of reward system for doing those things makes sense. But until that point, I think it needs to be a little less mechanized and a lot, not pilots, but a lot of testing and measuring to figure out how do we, make strides and gain momentum.
My knee-jerk reaction, remember, I'm not employed by CMS, I'm not a Medicaid actuary anymore, but I think people mostly should be. If you're not, here's your lesson. There's a really strong moral hazard to the financing of the Medicaid benefit, and people's interest is often into optimize, let's say, the use of federal funds to perhaps offset the state cost. And so this point that Rachael makes about the occlusion of data by I should rewind and erase that. Hiding data inside of managed care, I would say if there's a strong defense for applying that kind of risk adjustment and distributing your risk, and you can defend it, it's going to be in that in the rates that you provide to CMS and to the Medicaid managed care rate review team. Hey guys, we just have to trust that they're putting in what they believe is actuarially sound and true to the cost and adjusted appropriately for the population they're trying to cover. And I know that from the team that's doing that work that if it's well measured, well explained, well defended, that risk adjustment, as you indicate in your rates, is I think totally acceptable and defensible. But
one thing that Medicaid does do well, and it's like each state has multiple Medicaid programs, right? It's a big experiment. I know I've seen with the state of Minnesota is some of their quality measures are looking at, okay, how are you making strides in addressing disparities? And one of the challenges in the commercial space is that we don't really have standardized quality metrics where you can have a provider focus on a single set. And so that may be one place in the commercial space where we could draw from Medicaid and look at, okay, how do we get a standardized set of metrics that look at quality and then start to slice the data by population quartiles or whatever to start making strides there.
Okay, we have 2 questions from the virtual audience. The first is sounds also like an offer to help. Public health and health advocates may already have some of this outcome data that you're looking for. Do you have any ideas or thoughts about how they can partner with actuaries or others who are doing the pricing evaluation to kind of share that information?
Yes, work with the Health Equity Committee. Call Becky.
Very good. Another question. One virtual audience member shared that they have experience pricing new benefits, and that one method they used was working directly with the providers to collect data. So has that come up, or what are your thoughts of kind of getting that data firsthand from the providers?
I think that's your first go-to. Like they sit on a mountain of data that they do understand very well. And when you're trying to think how their new benefits going to affect your population, you at least need something to check against the reasonability. I think what the carriers and vendor partners cannot do, and this isn't their fault, is help an employer understand holistically how some of these benefits are going to affect things outside. And this is something Rachael talked about too, like 20% of it's health, but then you have the rest of it happening outside. And so looking at health and safety, or, it just turns out that sick people aren't able to work well. Absenteeism, presenteeism, which is even worse, it's incurring costs that are living outside of your health plan. So it's just consider the costs of overtime, turnover, retraining, salary compression, and having to get someone to come and do a third shift. There's just a greater need to make a stronger case for how employee wellness and well-being can actually affect people holistically, and it's more than just the medical cost. So.
Great.
Yeah, I would just add, all new data is good data, with the admonition that sometimes it's the data that's not provided that is most problematic. So if you have data on 90% of the members, we say, hey, that's really good. Well, what's going on with that other 10%, right? Is that really the group we should be focused on, and why we don't have that data? Just as sort of a general data analytics comment.
Excellent. Awesome. Great. Thank you so much. Is it time for lunch?
It is. So we're going to take a break for lunch now until 12:30, but first I want to thank all of our panelists and Andie for moderating. And for those of you who are joining virtually, we'll see you back here at 12:30.
Excellent. Thank you.